Khaled El Emam is a associate professor at the University of Ottawa, a senior fellow at CHEO, Children's Hospital of Eastern Ontario, and the Canada Research Chair in Electronic Health Information at the University of Ottawa. So it's our pleasure to have him here to provide us with his thoughts with regard to managing personal health information, and in particular the de-identification areas that he's been instrumental in helping the Ontario Brain Institute with in terms of brain code. So Khaled is coming in by phone, and so we should have him on the line. So over to you, Khaled.
Thank you very much, Ron. Can you hear me?
Yes.
Yes.
Okay, perfect. Well, thank you very much, and thank you, Anne, for that wonderful description of the work that we're doing. So I will cover two main things. One is I will talk about the identification methods in general, just to explain a little bit about how they work in practice and the reasoning for employing them, and a sense of the major concepts around de-identifying health data. And then the second thing I will talk about is anonymous linking, which is a set of techniques that allow us to link different databases. And both of these, the anonymization and the anonymous linking, technologies are being used at BrainCode to facilitate the sharing of certain types of information. So I think we'll just advance to my slides in a moment. There we go. Okay. So when we talk about anonymization, I'll use the term anonymization because it covers the identification as well as a few other techniques as well. So we apply and have applied anonymization methods to clinical data sets, which include structured and free-form text, administrative data sets, surveys, and images to some extent. And all these types of data sets are currently being collected or potentially being collected within the context of BrainCode and research sponsored and supported by OBI. I'll talk a little bit about images now because I will not cover it in depth later on. Our colleague Stephen Strother, has developed and provided to BrainCode a method for identifying images, and that centers around the removal of headers from DICOM files. This is really the current state of practice with the anonymization of images. It's mostly focused on DICOM files and the removal of the embedded tags within those files. There's some research work being done on blurring of images to hide the facial features. I would characterize that as really on the research side of the equation, with possibly a few more years left of work to be done before those methods are ready for prime time. And that's where we are with image data. So in the context of anonymization, I will focus on the top three bullets: clinical data sets, administrative data sets, and surveys, and what techniques exist for anonymizing them. Then I will talk about anonymous linking. So we'll start off with anonymization. As Dr. Kavukian had mentioned, we had published one book earlier this year called Risky Business. So this is it covers policy and legal issues with respect to anonymization and different standards that exist. We've published two other books, which, if you're really interested in this topic, then you may find them useful. The Guide to the Identification of Personal Health Information. So that's a methodology book which covers a risk-based approach, which I will describe momentarily, for de-identifying health information. And the middle one, with the published by O'Reilly, with the herring swimming upwards. That's a book of case studies where we describe a number of case studies varying from the very simple cross-sectional disease registry databases to quite complex electronic medical records and insurance claims databases. So it describes the issues around anonymizing those data. The key point here is there's a lot of good reference material, and the approaches can be applied to quite complex data sets with a strong eye to ensuring data quality. So, and this is really important to emphasize that many methods that have been developed, when applied, the more advanced methods, when applied properly, they can result in high-quality data coming out at the other end. So the anonymization will not necessarily have a negative impact. If done properly, it will not have a negative impact on the analytics or the data analysis that can be done on the data afterwards. So in terms of what is why should you anonymize data sets? So in general, sometimes it's not practical to obtain consent for just the number of individuals involved, being able to contact them after the data was collected, and so on. There's strong evidence that consent introduces bias in data because consenters and non-consenters differ on some important characteristics. Basically, all your typical confounders are often different between the consenters and non-consenters. There's evidence that data custodians are generally reluctant to disclose personal information, even if they are permitted to disclose that information. So the information sharing culture errs towards not sharing rather than sharing, and I suspect many of the attendees have had experiences with that. As Dr. Kavukian mentioned, there's in Ontario's PHIPAA, as well as laws in other jurisdictions. In the U.S. is called minimal necessary, for example, under HIPAA. There's a general requirement to limit the amount of information that you disclose or use to only that information that is necessary to achieve the purpose. And that also implies anonymizing data if anonymous data will serve the purpose as opposed to identifiable information. Anonymization helps maintain public trust. The public trust is very important. Various surveys that have been done over the years show that the public changes their behaviors when they have concerns about how their health information is going to be shared, and those behavior changes or privacy protective behaviors are detrimental to the patients, but also could be detrimental to the quality of the data. There are other ways to share data apart from anonymization, and they all have some important disadvantages. And if you're interested in that topic, I can certainly address it in the questions. There's now an expectation, and in some jurisdictions, a requirement to notify individuals if there's a data breach, and the costs of these breach notifications can be quite high. Depending on the jurisdiction as well, it could go. The average number in the U.S., for example, is $200 per record. So if you lose a database with 1,000 records, the average cost is $200,000 to notify penalties, litigation, etc. After the fact. Anonymization avoids notification, these breach notification costs. So as an insurance, it's a very effective insurance, given that the probability of breaches occurring is actually high and continues to increase. And then the other point to remember is that there's a whole science of the re-identification attacks that is emerging. A few weeks ago, Code of Conduct for Data Attackers was published because there's a whole body of researchers who are building a career on attacking data sets and ensuring how the data can be re-identified. So the argument that nobody will do this is holding less water, because there are researchers and academics in prestigious universities now across the world who only do re-identification attacks and develop techniques to re-identify data sets. So it's something one needs to care about and consider seriously. So hopefully made a good case for the need to anonymize your data. There are practical as well as legal reasons to be doing this. So now I'll talk a little bit about anonymization. When we're anonymizing a data set, we divide your data into the variables into two groups: directly identifying and indirectly identifying, or quasi-identifiers. Directly identifying variables are things like name, address, telephone number, medical record number, health card number, etc. And then the quasi-identifiers are things like sex, date of birth, or age, any kind of geographic information, demographics, and socioeconomic status data. Both of these types of information can identify individuals. So when we're anonymizing a data set, we really have to worry about both these types of fields in a data set, whether it's a structured data set or free-form text. If it's free-form text, we still have to extract this kind of information and deal with them. So usually, in the context of conducting a study, of course, you need to know who the patients are, or who the subjects are, or participants are. You need to know their name and address and so on in order to follow up, do follow-ups and reminders. So in the context of a study, direct identifiers are necessary. But then when the study is finished and you're starting to use or wish to use that data for secondary purposes, or link that data with other data sets and conduct additional analysis on the linked data, you will generally not need to have the direct identifiers. So in most secondary use scenarios, the direct identifiers are removed. However, we do care about these quasi-identifiers or indirect identifiers. And the indirect identifiers can still re-identify Canadians. So the result I will show you has been replicated in other jurisdictions as well. In Europe, for example, the results are very, very similar. And in the US, they're not as dramatic, but they're still quite high. The risks are quite high. So what I'm showing you here is based on an analysis we did in Quebec. We obtained data from the provincial health insurer, the RAMQ, for 1 million Montrealers over a period of 11 years. And so we looked at the re-identification risk of those individuals, and this work was done with our colleagues at McGill. So on the x-axis on this graph, you see the number of characters in the postal code, which is one of the quasi-identifiers I mentioned earlier, and on the y-axis is uniqueness, which is a classic measure of re-identification risk. And as you can see here, when we looked at the data sets that we have, the Montreal data set, if you have the 6-character postal code, and up here you have the full date of birth, so you have date, month, and year, about 95–96% of the population, so these are population estimates, 95% of the population is unique just on those 2 pieces of information. So essentially, and I'm comfortable generalizing this to other urban Canadians. For rural Canadians, the numbers are a little bit lower. They're still high, but lower. But let's say for now, for urban Canadians, the date of birth and the 6-character postal code is essentially a unique identifier. This graph is based on all individuals. If we limit it to adults, we're defined as 20 years and above. About 99% are unique on the full date of birth and the postal code. And as you can see, uniqueness drops down slowly until you get to about 3 characters of the postal code, and then it drops dramatically. The key point here is that these quasi-identifiers, these basic demographics, make individuals unique. And this kind of information is readily available that can be used to identify individuals. There are public registries, public databases that contain information, this basic demographic information. And also, people now self-reveal a lot of information about themselves. And if we reduce the date of birth to year of birth, then the risk goes down dramatically. So from the 6-character postal code and the year of birth, only about 68–69% of the population is unique. So the key point here is that by generalizing some of the information, in this case the year of birth, the risks can go down. And of course, if you have year of birth and the 3-character postal code, then your risk is, there's no risk, it's 0 basically. And then the other point to keep in mind is that longitudinal data has a higher risk than cross-sectional data. So when we looked at the individuals over a 3-year period by essentially looking at their movements over time, where they lived at the beginning of each year over a 3-year period, that's the green line, and the risks go up. And of course, when you look at 5 years and 7 years and 10 years, the pattern of movement becomes unique or make individuals quite unique. So here we only looked at date of birth and postal code, but if you look at other types of information, for example, you look at rare diseases, if you look at years of education, number of children, income, and so on, all that information is obtainable or knowable about individuals and can be used to re-identify those individuals in a research database. So how do we de-identify this data? Just at a high level, we look at identifiability as being on a spectrum, and here the spectrum is a probability of re-identification, and based on many precedents, we generally try to ensure that the probability of re-identification is between 0.05 and 0.1. At the higher end, 0.1, that is consistent with existing practices for sharing personal information. This is health, education, justice, and census data. And then at the other end of the spectrum, 0.05 is generally what you would use for public data releases. And for non-public data releases, we'll err more support towards a 0.1 overall risk of re-identification. or probability of re-identification. So in that case, when we have some confidence that the data recipient, so in this case, let's say a researcher, has good practices in place. And I can tell you that the difference between a 0.1 and a 0.05 in terms of data quality is significant. So at a 0.05 threshold, you're going to de-identify the data more, you're going to make more transformations to the data, and you will inevitably get lower quality data. And at the other end of the spectrum, you'll get higher quality data. Then the next question is, well, how do you decide which one of these values on the spectrum should you use? Well, actually, before going there, the other point I wanted to mention is generally we don't have a threshold higher than 0.1 because the risks are high. We know that re-identification attacks occur, and we will really want to stay within the range of precedence so that we can justify the thresholds that are used. And we don't go below 0.05 because below that threshold, typically your data set is modified more than most people would like. So we generally try to limit it in this range, which is still consistent with current practice or precedence. So how do we determine what points on the spectrum to use? There's a risk assessment process that one would normally go through. Again, this is consistent with practices that have been going on for many decades. But we essentially look at the mitigating controls, which are the security and privacy practices that the researcher has in place. So if you're giving a data set to a researcher, that's the scenario that I'm considering here. If you're giving data to a researcher to execute on their own site with their own tools, etc., which is often the preferable way to share data, then we look at the security and privacy practices that researcher has in place. So if the researcher has good security and privacy practices, then the amount of data identification will be reduced. And if the researcher has poor security and privacy practices, then the amount of data identification will have to increase to compensate for these poor practices. And then there's an invasion of privacy test, which looks at the sensitivity of the data, consent, potential harm to patients if there's an inappropriate disclosure. And then motives and capacity really consider whether the researcher is motivated to re-identify the data set or not. So for example, if there's a contract or a data sharing agreement with the researcher that prohibits re-identification, then that arguably that contract then reduces the motive significantly. So you can manage all these risks through imposing particular controls to be in place in terms of security and privacy practices, by eliminating or keeping, depending on the needs, sensitive information in your data, and by having contracts in place. So there are a number of levers that can be used to manage the risk, including, of course, de-identification. De-identification is only one of the levers that you can use. But if you want to retain higher quality data, you can use one of the other levers to give higher quality data, but then impose controls in another place in order to have to make sure that your risks are managed. So that's the process we've been using thus far, and that's the process that is currently being implemented within the context of BrainCode to facilitate the sharing of the data for secondary purposes. And the types of data transformations that we're talking about are generalization, suppression, subsampling, and shuffling. These are standard techniques for anonymizing data sets, and again, they can be done in a minimalist way to ensure high quality data comes out at the other end. Okay, so then I'll go quickly over the second approach that we've been using, which is anonymous linking. And the basic idea here is that there's a need to link data sets. There's a need to link data sets from multiple studies. There's a need to link data sets collected by OBI researchers to other administrative databases, such as databases that exist at ISIS, the Institute for Clinical Evaluative Sciences, for example. The challenge, of course, is that the best fields to use for linking records across multiple studies are these direct identifiers. And as we said before, we generally don't like to keep direct identifiers after the primary purposes for collecting them, such as conducting a study, is completed. So anonymous linking allows you to use homomorphic encryption, which Dr. Kavukian had mentioned in her presentation, to allow the collection of this kind of data, the OHIP numbers, date of birth and name, and so on, encrypt them at the source when the data is originally collected, and then use that information either, if you have the OHIP number, that's generally sufficient by itself, but if you don't, you may use other fields. But essentially, you'd encrypt that information at source. So, for example, if you're using a browser to collect data, you encrypt it within the browser. And then that encrypted data can be used to link records across databases. And the big advantage of using this type of cryptography is the kind of cryptography or crypto system that allows you to perform mathematical operations on the encrypted data. So it allows us to do comparisons, for example, and do equality tests to determine if two records are the same or not. So I'll give you a quick overview of the protocol, and then I'll close so as not to eat up too much time. So this scenario that I'm looking at here is linking records from OBI with records from ISIS, and without actually sharing any personal information, because well, there are issues around the agreements that would be necessary and authority to share this kind of information. So the objective is to facilitate the linking without sharing revealing any of the personal identifiers. So as you can see, there are three parties in this protocol. There's OBI, there's ISIS, and then there's us at the kind of orange circle in the middle. So the first part of the protocol is that we issue public keys and send our public keys to everybody, to both ISIS and in this case will be brain code. This is a public key to facilitate this type of homomorphic encryption, and we retain the private key. The next step would be for brain code to encrypt all of its data. In this case, we're assuming that the data that will be used for linking is the OHIP number. So all the OHIP numbers are encrypted, using the public key, and then the encrypted data is transmitted to ISIS. So ISIS does not get any identifying information, because all the identifying information, in this case the OHIP number, would be totally encrypted. And ISIS doesn't have the private key to decrypt that data. Then ISIS would pull out its own database that we're linking with. So for example, let's assume it's the DAD, the Discharge Abstract Database. So ISIS would take the DAD and would encrypt the OHIP numbers for the records in the DAD using the same public key. And then they would do an equality test. It's a homomorphic equality test, which compares the two encrypted OHIP numbers from the two sources, from the ISIS DAD and from the brain code research study. So that equality test will be conducted, and the result of this equality test is essentially an encrypted yay or nay result. And so that encrypted yay or nay result is sent to us. So ISIS does not know what the result is, because the comparisons are done on encrypted data, and the results of the comparisons are also encrypted. So then we use a private key to decrypt the comparison results. So now we know which record pairs are the same and which ones are not the same. And we send this final result to the end user, who may be a brain code researcher, or maybe back to OBI. So the end user, of course, will be determined by context. But that's the basic protocol. It's provably secure in the sense that no single party in this protocol can get access or view OHIP numbers that they're not supposed to view. And at the end of the protocol, the linking can be achieved. And this serves the purpose of deduplicating data sets, of doing secure lookups. If you want to know if a patient in one database shows up in a second database without actually revealing the identity of the patient, who the individual is. And of course, it's also useful for linking two complete data sets to determine which records are the same. So you can do this linking you can do exact matching on OHIP numbers. You can also do approximate matching on strings, so you can compare names, for example. At this point, we're working on a probabilistic matching version of this protocol as well. So that way, then secure probabilistic matching can be completed. But the exact matching protocol is done, and it's now in pilot phase. And I will, if you have any more questions, of course, please contact me. And I will leave it at that. Thank you very much.